Hello, and welcome to another Spotlight the Science, where we get to meet the researchers who received research funding from the American Diabetes Association. My name is Marlon Pragnell. I'm VP of Research and Science at the ADA, and today we get to speak with Dr. Anjali Gopalan. Dr. Gopalan is a research scientist in the Kaiser Permanente Northern California Division of Research and a senior physician in the Permanente Medical Group in the Department of Adult and Family Medicine. She received her MD at Washington University in St. Louis and a master's in health policy research at the University of Pennsylvania. Broadly, her research focuses on identifying ways to better align type 2 diabetes care with patients' individual needs, preferences, and capacities towards the goal of improved health. And she's particularly interested in developing interventions to address age-related and racial ethnic disparities among individuals with newly diagnosed type 2 diabetes. Welcome, Anjali.
Thank you so much.
So tell us a bit about your research. You're focusing on newly diagnosed younger people, younger adults. Why that area?
Yeah, so, I think that one of the things that came to me through clinical care is I realized that our type 2 diabetes care is often one size fits all. So it was really kind of tailored to maybe the patient that was very typical 20 years ago. So an older adult who's already used to navigating the healthcare system, who is now being diagnosed with type 2 diabetes, in addition to maybe hypertension or, other kinds of chronic diseases. But we're seeing a growing number of people who are diagnosed in their 20s, 30s, early 40s with type 2 diabetes. And one thing we do know, and research has shown, is that earlier onset of type 2 diabetes actually portends a worse outcome. So not only are people living with the disease longer, so the risk of complications is higher, there seems to be something, inherently different about getting type 2 diabetes at a younger age that makes you more likely to develop micro and macrovascular complications years later. And at the same time, I think the challenges of trying to manage it, as a 35-year-old are very different than the challenges of trying to manage type 2 diabetes as a 75-year-old. You may be navigating very different life demands. So, trying to build your career, establish financial independence, the big one, raising, young children, navigating aging parents. So I think that the sort of environment in which people are getting this diagnosis and trying to manage things is very different. And so I think looking at that really struck my interest. And at the same time, we have this growing knowledge that the glycemic control that you achieve early following your diagnosis has lasting effects. So if you can achieve more optimal glycemic control or blood sugar control during the time, following that you're diagnosed, even if you can't maintain that for the duration, it still has an effect, 10 years later in decreasing your risk. And I think also logically, we think about people get this life-altering diagnosis. So somebody tells you have type 2 diabetes. It may be this window where your motivation for making really hard changes is higher. So, I think we know of stories that people get diagnosed with, emphysema, and they're able to stop smoking, or they get, diagnosed with high blood pressure, they're able to change diets. And I think type 2 diabetes has some similarities. You get this diagnosis, and maybe it's a moment where we can help support people make really difficult changes. So in terms of their diet and physical activity level and stress management. So I think, go ahead.
But when you're young, I mean, there's so much things happening in life and so on, raising a family. And but then getting diabetes at that age as well, then must be particularly challenging. And then you said also too that it's so important to kind of maintain good glucose control. So those are really challenging things to accomplish all within that kind of context.
Yeah, absolutely. And I think that, unfortunately, I think that there's been a misperception amongst clinicians that, oh, this person is young, we don't need to worry about this as much. They have time. But the data shows us that we should actually be more worried about that person, given the increased risk. So we should be doing more to help that person make the changes that can control their blood glucoses. And for some people, actually, bring their type 2 diabetes into remission. And I totally agree. I think in addition to all the different life demands, there's this sort of other elephant in the room, which is the stigma that a lot of these young people feel. So, they're thinking, I got type 2 diabetes, I'm only 35 or 40. I did this to myself. This is something that I brought on myself. And, which I think it's important that we disabuse people of that erroneous kind of self-blame, given that we know how complex the causes of type 2 diabetes are. And also for many of these younger people, one of the biggest risk factors for getting type 2 diabetes at a younger age is having a strong family history of type 2 diabetes. So they're getting this diagnosis also in the face of maybe aging relatives who have been living with type 2 diabetes and maybe developing complications from type 2 diabetes or even have died as a result of their type 2 diabetes. So it's a really complicated situation that you're entering this new diagnosis into, and so how can we better support people in this very complicated, both emotional and physical and medical, situation?
Yeah, and yeah, from the work that we're supporting, we're funding. It's you're looking more at the Latinx Latinx population, right?
Yes.
Younger adults, and so what are the unique aspects? What are the unique issues there that might be
Yeah.
challenging?
So I think, one of the drivers of that interest is really looking at the numbers. I think we're seeing in national level data that the average age for a Latinx individual for being diagnosed with diabetes is actually now under 45. And I work at Kaiser Permanente in Oakland, California. So the population I'm looking at is within Northern California. And in our population, when we look at the overall, if we look at people who are diagnosed with type 2 diabetes at a later age, we see that the percent of people who are Latinx is about 22%. But when we look at people who are diagnosed before 45, it's actually 35% of the population. So, disproportionately impacted by this younger onset of type 2 diabetes. And I think this comes up against a couple things, which is we do know that many of these individuals have that strong family history that I mentioned, and so are thinking or dealing with that. There's also two things that have been noted to be more prevalent amongst Latinx individuals, and one is diabetes fatalism. So the idea that the individual feels like they have less control over the outcome. So feeling like there's nothing they can do to change the bad things that might happen related to type 2 diabetes, and also the central role of family. So the natural sort of cultural value of placing the family's well-being over the individual. And that can be, at odds, on the surface can be at odds with self-care, right? And the things that people need to do, the time they need to take for themselves to manage their type 2 diabetes. And so some of the intervention that, I'm happy to talk more about is really, how do we help people realize that self-care is actually family care, right? The things that they do for themselves are actually impacting the people around them. So, in the intervention that we're so lucky to have funded by ADA, we're really thinking about how can we tailor initial type 2 diabetes care to younger Latinx adults who are parents to children. So people who are raising children who are under 18. And this is really rooted in work that we found where we saw that children had this really interesting effect on their parents' perceptions of their type 2 diabetes. So people who had children reported that their children were one of the primary motivators for them to get on top or get control of their blood sugars. They wanted to be well and healthy to take care of their children. They wanted to live long lives to see their children grow up, to see their grandchildren. They wanted to model healthy behaviors for their children. And they were really acutely aware of their children's type 2 diabetes risk and wanted to break that cycle. So what can we do to prevent my children from getting type 2 diabetes? But at the same time, children were also a huge barrier to type 2 diabetes self-management. And I think, I have two young children, so I can relate to this, is time, right? In the setting of limited time, people naturally felt that their children's needs came first. So, when they had to make decisions about, how to exercise versus doing something for their kids, it was hard to balance those things. And then also when it came to medical, resources, some people even said, like, I was going to go to the doctor and then my kid got sick and that took priority. Or when we have limited money for certain things, my kids' needs took priority. And so I think seeing that, we were really interested in how can we tailor the education we provide to really leverage the motivation that children provide their parents in terms of type 2 diabetes self-management, acknowledge people's concerns about their kids' type 2 diabetes risk, and then also maybe offer people some strategies to deal with those like kind of very practical time demands and priority kind of related conflicts when it comes to their kids and their type 2 diabetes.
So you said you're doing an intervention. You're going to test. How do how do you develop an intervention? What are the steps to kind of knowing what to do and how to intervene and to guide, and take us through how you do a
Yeah.
research project like that.
I think that we started with this premise that the information that we were providing and the services that we were providing to these younger adults weren't adequately meeting their needs, right? So we took a step back and thought about what are the materials, or what are the ways that we are providing care, and how could they be better? So, for this intervention development, we really wanted to focus on the messaging from the healthcare system. So for Kaiser Permanente has, for example, a repository of resources. If you go to our online webpage and search diabetes, there's hundreds of videos that we've made to help people with different questions, ranging from, tell us about insulin to tell us about, kind of a plant-based diet. There's, a lot of different things that people can look, but that can be really overwhelming if you're going through all the things I just mentioned with your type 2 diabetes in your life. And so one of the things we wanted to do is how do we curate that so that we're really delivering the most high value content along with clear messages to people. So for example, how do we make sure that, if you only have 5 minutes to think about this, that we've delivered a message that has high value, linked you to important resources. And so we went through the process of actually engaging younger Latinx adults in talking through what would be helpful and what would the timing of information be, what would be too much, what would be too little, what resonated with their kind of lived experience. And so we talked to people who are about a year out from their diagnosis, because I think that gave them the ability to reflect, but it was still recent enough that it was fresh in their mind. And it was really insightful to hear what people said, about this kind of information was just fear-provoking, or just left me with more questions, and it didn't really answer my kind of immediate things. And we've, based on that, sort of developed a series or a set of messages that we're going to test. And the messages have this the structure that we're hoping will allow people to engage on different levels. So the message itself might say something that we know might be a concern. So for example, many people are worried about their children's risk of type 2 diabetes. And, luckily there are many things that we can do to decrease your children's risk. And so kind of really calling out that, and then at the same time, providing links to how do you go to a nutrition class, some videos we have on, the importance of decreasing sugar sweetened beverages. And then also ways for people to link and say, I actually would like more help with this. And so we're hoping with that kind of level of ability to kind of engage differently, we'll capture people. And we're going to do this via text, because that's another thing, is when we talk to people, we didn't just learn about what they wanted to hear. We also learned about how they wanted to hear it. And I think that's something that, we as healthcare providers and healthcare systems need to start to adapt to, is nearly everybody said, can you just text me? And I think that's sort of a reflection of the time. And I think also people said the videos need to be shorter, right? I think, people's ability to sit down and watch a 20-minute video are very different, but people have the bandwidth to maybe watch a minute, think about that, and maybe, a few days later, watch another minute. So we're really trying to think about not just the content of what we're sharing with people, but also the modality in which we're sharing it.
Nice. That's great. That's great. So you want to resonate with that. So have the most impactful messaging, concise, short, helpful for the demographic of the group of people that you're trying to reach, right?
Exactly.
Also,
and then
but also to the one thing I was reading in your writings. I mean, you have the perfect environment in a sense to kind of test this, because you have you have access to a huge number of patients. You can monitor their prescription use and so on. Talk a bit about that, about how the cool features you have within your program that allow you to kind of study this and see how it works.
Yeah, absolutely. So, when I was making a decision about where I wanted to do research and where I wanted to practice, one of the things that drew me to Kaiser Permanente was that it is an integrated healthcare system, meaning that, everything happens within one system. We don't necessarily get, and so because people are kind of in our system and we're really responsible for their overall health, there is this focus on prevention, right? And what we can do for that. And then also we have this ability to capture a lot of data. So, people who have been members, we can see what their blood sugars have been over time and what they are in the future and how they're filling their medicines. And so it's really unique in that way. And there's also a lot of sort of existing infrastructure to test some of these things about education strategies and messaging. and which I think is really great. And it also helps us, because people have relatively equivalent access to different diabetes care. We've sort of overcome one of the issues, which is, people not having healthcare at all. And so, when people do have healthcare, how do we deliver it, more effectively? And then how do we capture all this huge range of things that might happen? So, we're lucky to be able to capture things like the medication initiation and whether people actually refill their medications, but also things like, we do capture people's self-reported exercise or physical activity, people smoking and smoking cessation. And we can also actually capture whether people attended health education classes. So did people actually go to a nutritionist? Did people go to a behavioral health visit? And so it really helps us get the full range of what our intervention might be helping with. And I think that when you see that, you can kind of get an idea of like, oh, we really are seeing that this is helping shift people to a certain action, and which I think is really exciting. And I think the other part that's really exciting about being this kind of system and where we are located is that most of these people who have type 2 diabetes, their children are also KP members, right? So, my goal is we are working towards an intervention that might actually involve the children as well. Because I think for us, right, when you're taking care of both the parent and their child, an intervention that could help the parent improve their type 2 diabetes control and also help decrease the child's risk of type 2 diabetes seems like a no-brainer, a real benefit for everybody.
For sure. And I imagine this approach could work for multiple various groups. So, I mean, I know you mentioned about familialism and fatalism in the Latino community, but I mean, there must be elements in other communities as well, some priorities and so on. So I can imagine that you could target this or tailor this or modify it as needed to kind of resonate with other groups of people as well, right?
Absolutely. And so, I mentioned the disproportionate sort of like impact of younger onset type 2 diabetes amongst Latinx individuals, but within our population, we also see a disproportionate population of Asian individuals in the younger onset population. And, we know that those younger individuals tend to be more likely, where we live in Northern California, a large population of them are Filipino. And so that is another population that I think could really benefit from some more tailored outreach and has some similar things around fatalism and the priority of family over the individual. So it's definitely something that we've explored and would love to take these methods of engaging patient stakeholders and developing interventions and apply it to other populations. I think for me, the Filipino population is one that comes to mind, just given our location.
It's very interesting how you do the research you do. So when you develop your intervention, you go out to the community and engage stakeholders and understand and discuss and ask people what's relevant, what's meaningful for them. So you do that. You did that for the Latinx community. So you do it for the Filipino community, for example. That's how you create your intervention. Then, so how you design it using all this stakeholder feedback. Then, right?
Exactly. And I think as a clinician, those conversations have been so fascinating, have really informed my clinical care as well as my research. So the ability to talk to patients who are living through it in this setting of just tell us what we're doing well and tell us what we could do better is eye-opening. And I think people are really willing to give feedback. When we recruit patient stakeholders to do these interviews, they know that it's not going to necessarily change their experience. They've already been through it, but they're really excited about how they could help future people in their situation make that experience less tumultuous, less stressful. And so it's really exciting, and people have wonderful ideas. For example, this one woman we talked to recently said, one of the things I really struggled with is how do I even talk to my child about type 2 diabetes? So she had an 8-year-old kid, so not a baby, but not a teenager, right, who is noticing that his mom is making a lot of changes. She doesn't want to scare him by telling him why she's making all these changes, and she's also worried about his risk. So she was like, I would love just language on how I can explain to him why we're making these changes without making him feel bad and without scaring him. And I thought it was just such an insightful comment, and something that we have not thought about, or we don't have materials for. So talking to patient stakeholders is just amazing. The ideas that they come up with are really, really phenomenal.
Yeah, the insight and the lived experience is so important to
Absolutely.
understand that and fully appreciate that, to kind of develop ways to help people address their diabetes. This has been fascinating, and the work you do is so important and so interesting. And so we're looking forward to kind of great data in the future. And I know
Yeah.
that once you collect all the studies and so and provide these text messages, these information, these guides, and so on, hopefully that will improve care, how people can take care of themselves, improve glucose control, and so on, and reduce complications in the future.
Yep, that's the hope.
So,
The hope is that if by meeting people where they are at, by providing the information that is helpful for them to take actions a little more easily, in spite of all the demands that are going on in their lives, that we can really help people engage and take the steps to improving their blood sugars, and hopefully that can have a real positive impact on their health going forward.
so important. Thank you